Everyone, my name is Kit, and I am the founder of this Bertolotti Syndrome platform. I've been hosting these monthly meetings, and in this meeting, we have a very special speaker today with Andrea. And Andrea, she did her bachelor and her master in occupational therapy, so she's actually an occupational therapist. And in addition to that, she is doing her PhD at Old Dominion University. And she has a very special study going on where she looks at Bertolotti syndrome. And I think that's great. I think it's amazing that you're doing that work, Andrea. I would love to hear more about that. Before we go into that, would you like to share anything about yourself or how you even got into this and how you even created this or found this? And I would be very interested to know how. Yeah.
Thank you for that introduction. So my name is Andrea Oliver. I've been an occupational therapist for over 10 years. And towards the last half of my practice, I was going to work every day and just noticing some nagging low back pain that wasn't going away. So like so many of us, I went to the doctor, I went to PT, it wasn't getting better. And with my rehab background, I was noticing that like I'm doing all of my exercises. I have a great PT. I'm biased because it's one of my personal friends, but what am I doing that's not working? I was previously really active. I was hiking, I was running, I was doing CrossFit, I was lifting weights, and what I was noticing was that I wasn't progressing lifting weights. My squats were getting worse, and I was keeping up with the 80-year-olds in the CrossFit class instead of the 30-year-olds. And I was like, well, okay, I've been here a month or two now. Like I should be progressing past this point. What's going on? So that's when I started pushing my doctor for imaging. Sorry for the squeaky toy. I've got a dog under my desk. But once I started to get in the imaging, it came up with, oh, transitional anatomy. So having that clinician background, I was going, well, what is that? I've never heard of that. I've taken anatomy. What is this? And I started finding more and more about Bertolotti syndrome. And then I was looking at my imaging, looking at the Castelvi classification, which was the norm at the time in 2020, 2021, when I first started getting diagnosed. And I was looking at it and I was like, this looks like what I have. I'm not a radiologist, but after comparing images, after reading some of the scholarly journals, I started to pursue it more and then got a formal diagnosis by Dr. Jenkins, did the diagnostic injections, and have been continuing conservative treatment ever since. So I haven't yet undergone surgery, but that is something that I'm kind of holding on to in the future. But it doesn't really line up really well under a PhD timeline. So I'm trying to find a better time when I have a full time to recover and I don't have papers to stress about. And ultimately, that's what led to me developing this study. So this is my second study that I'm doing with Bertolotti's patients. A lot of you guys have actually participated in my first survey study. This one starts out as a survey and then has an in-person component. So if you guys are willing, I would love to share a little presentation I made about this project.
Thank you, Andrea. Yeah, thank you for sharing your backstory, um, and especially, doing the study while you're going through Bertolotti yourself. That's very impressive. So thank you for doing the work. Yeah, you can go ahead and share your screen, and the floor is all yours.
Okay, so I'll start off telling you guys about this study. If you have any questions, please hold them till the end, and I promise I'll answer them and pull back the slides as needed. So this is my current research study. It's called Bertolotti Syndrome and Quality of Life, a multi-method exploration of lived experience and functional status. So what this means is I'm not just looking at the anatomy, I'm also looking at us as people because we know that this affects us greatly. As I've said before, I have over 10 years of clinical experience as an OT, and I myself have type 2B Bertolotti syndrome using the Castelvi classification or the Jenkins, depending on who's interpreting my imaging. I'm really passionate about interweaving lived experience into clinical research and advocacy because I think that is so needed in the healthcare field. So for this study, it has a long title because it encompasses 4 separate research aims. So I'm looking at health-related quality of life, posture, balance, and walking gait. So to design the study, one of the limitations that we're talking about is saying that we're researching a rare client population. So as a researcher and as a PhD candidate, there's a fear of, I'm not going to reach enough people. I'm not going to reach enough people to meet my data saturation goals, and therefore the study won't be completed. So to try to combat that, I've designed it in two parts, where the first part is entirely online, so I can reach Bertolotti's patients across the globe from anywhere. If you have internet access, you can participate in the survey. Unfortunately, it is only written in English because I don't have any extra language capabilities. And then the second part, you come to Old Dominion University, where I complete in-person clinical testing on you. I am at this point trying to find some satellite research sites if I can't get enough people to Old Dominion University. So if you're taking the survey, there's a spot to let me know where would work for you if Norfolk, Virginia doesn't work for you, because I know that's not realistic for all of us with chronic pain to travel. And that's why it's set up like this. So even if you know you can't make it in to see me in person, I would still love your data for the online part, because that helps me answer 2 out of my 4 research aims and really adds to the literature on Bertolotti syndrome. So the first aim is hidden in the online portion, and that's just looking at your health-related quality of life. And I'm measuring that using the 36-item short form survey instrument, aka the SF-36. And that is a really well-studied research instrument that looks at how your quality of life is impacted by chronic pain. Aim 2 is also online, and that's looking at your posture parameters. So to do that, I have participants upload 4 photos of themselves. It works best if you have someone else to take the photo if you're not good at using auto capture or a tripod. And the reason we have you take 4 photographs is because posture isn't a static thing, it's dynamic, and we want to analyze it from all sides, because we know that people are 3-dimensional, and so is posture. We're using the X, Y, and Z axes to analyze all planes of posture to see how our unique anatomy and our spines might be impacting our posture profile. So if you upload all 4 of these photos, I run it through this posture screen software, and it's giving me coordinates to help compensate for what I would do in a clinical evaluation, but doing it virtually and giving you a free posture report on what I'm seeing just based on your photographs. For aim 3, this is where the study moves to in-person data collection, because I don't have the ability to assess your balance over a virtual survey tool. So for this part of the study, this is where you would come and meet with me in person, and we would complete the Y balance assessment, which is shown here in this picture, where you stand with your feet together and then you try to bring one leg back as far as you can, or the other leg back as far as you can. And we just try to see what your single leg balance is like in all planes. And you only do it to the point that you feel safe. There's no fall risk. I would be right there behind you the entire time. And we would complete this with both the right and the left leg to give me a really clear picture of what your balance looks like. Because we know that as we're walking, we sometimes have to take a step forward, we have to take a step backwards, we have to take a step from side to side. And all of that piece is where we can start to see that postural sway or any kind of asymmetries. So the aim 3 is really looking at measuring that. Aim 4 is probably the most complicated part of this study, and that is looking at gait analysis. So, hang on. Sorry, no more squeaky toy here. So for aim 4, this is where you have a treadmill and you stand on the treadmill wearing 21 different little reflective dots. That allows me to use my camera capture system to create this skeleton. As you can see, our pelvis doesn't look like this. This is part of the software rendering. What is unique to us is where the dots are placed. These are matched perfectly to your anatomy. So to do this, you walk on a treadmill for a total of 5 minutes. I take several different captures between that time frame to just see what your typical walking looks like on a treadmill at a speed that's as comfortable as your normal walking pace. And then I compare your data to aged match parameters that are available through the CGA normative database. And what that looks like is better explained through a video. So as I play this, there isn't any sound. I want you to focus on what the left leg and the right leg are doing, because that's what I'm going to be capturing as I analyze everybody's data. And then the computer does a great job flipping it from side to side so we can see a full 360 view of what your walking looks like on the left side, on the right side, from the front and to the back. So I'm going to play it one more time, and this time I'd love it if you guys could kind of guess what you're seeing, because this is my test patient data. So this is what a typical, or my case, my version of type 2 Bertolotti's typical gait looks like. And if you have a background in gait analysis, you'll start to notice some asymmetries. So compare the different legs and let me know if you see anything the second time I play this clip. Okay, so hold what you see in your mind. And this is the report that comes out of the software. So the computer analyzes over 30 different data points and compiles them all together using a stoplight system. Green is good, yellow is, it's a little atypical, and red is, oh no, something is going on with that area. So as I was pilot testing this product, my screen lit up bright red, and all of my biomechanist friends were like, oh no, our sensors might be off. And I was like, no, this is my gait. I have atypical anatomy and I have an atypical gait pattern. So as you were watching the video, you might notice that one leg was slower and not moving as much. And that was caught really well in this capture system. So you could see the abnormalities lighting up on my left side more than my right side. And it's going all the way down from my hips to my knees to my foot and my ankle. And when it compared all of these different variables, it comes up with a primary factor. So if you could think about just one thing to fix, where would you start? That's kind of how you would think about your primary factor. It's the largest contributing score to your overall walking score. And for my primary factor, it was stance time asymmetry. So typically as you're walking, you should carry your weight equally from the right to the left leg. You shouldn't be standing on one leg longer than the other, unless your sacrum is partially fused to your pelvis and you really have to stand, hip hinge, and swing one leg over to compensate instead of having a smooth, fluid gait where it's equal from side to side. And watching my own data made me feel really confident that the system is specific enough to pick up our Bertolotti's abnormalities. Because one thing I've noticed as a patient and a researcher is that my walking time has slowed as I've had this diagnosis longer and longer.
Sorry, can I ask what part of you is fused when you're type 2B? What side
So
is
for type 2B, it's a little bit on both sides. My right side fusion is bigger than my left side for me personally, but that's individual to each of us.
yeah, because I have the fused vertebrae on my right, but I'm feeling everything on my left, and so I'm really intrigued by your results.
Yeah, so I would guess that maybe you would have a similar profile because it sounds like we have similar anatomy, and that makes our left side have to compensate so much more. And we know with a rehab perspective, whatever side is compensating is going to come up with more injuries, more wear and tear. It's doing more work than it needs to, so it's going to start to show symptoms
Yeah,
sooner.
thank you.
Yeah. So then after looking at all of that, it prints out a report showing all 30 of the variables. I'm not going to bore you with that because that's a lot of data that we don't need to go into, but it gives you an entire report. So you get a free gait analysis that you can take back to your clinicians, you can take back to your medical team, and that you can share it with them. And the nice part about it is it explains each term underneath of it. So you don't have to be a biomechanist. You don't have to know the entire 6-step swing phase of walking. You don't have to have any kind of background in this to understand their system. And it gives you the definition, and then right above it, it shows you how your left leg and your right leg compare. And best case scenario, our left and our right legs would be doing the same amount of work. That's how we are supposed to be designed. But we know that our atypical anatomy can create some atypical gait patterns. And for me, there was a really clear difference between my left leg and my right leg in this capture. So if you participate in the study, you would get the full-on report. It's about 4 pages long that goes through each of these factors. And I can send you a link to share this video file as well. And then ultimately putting this all together, why did I choose this? Why did I choose so many different variables? I think that clinicians, patients, surgeons needs to be aware of how our unique anatomy creates unique movement patterns. That's one really big thing that's missing from the literature right now. So much of the literature in Bertolotti syndrome is still focused on the anatomy and surgical corrections. But for so many of us living with this syndrome, it takes a long time to get a diagnosis, and it takes a long time to figure out what to do with the diagnosis after trying conservative treatment and then considering surgery to even get in and take all of those medical appointments. That's a good 1 or 2 year wait between diagnosis and surgery in a best case scenario for most of us. So the more that we can understand the clinical picture of what a Bertolotti's patients look like, the more we can help in the PT phase and the OT phase of treatment. And if we know what we look like before surgery, we might have a much better picture on where we need to go after surgery. Because if you have deficits in gait pre-surgery, you're going to have to do some gait training after surgery to achieve a normal gait. So this is just one area that I can contribute my rehabilitation background to the Bertolotti syndrome overall research. And so far, in its first week of being live, I have over 60 fully completed surveys, which is really exciting to see as a researcher. And the next part of this is really just keep sharing this, because we know that patients talk to other patients. So if you know one other person with this syndrome who hasn't yet had surgery to correct it, please send them my way. I still need to get 20 people in the lab to complete the gait analysis to really give us a clear picture of how Bertolotti's affects our walking. Now, what you're probably all waiting for, any questions? I would love to help you out as much as I can.
This is only open to US residents, correct? Because I'm in Canada.
No, it is open to Canadians. It is open to anybody who speaks English. So I would love to have more and more international people.
And just one more question, because I know I'm in Calgary and we have the University of Calgary has the Spine Institute.
Okay.
I have been trying, I emailed them a couple of times to try and get some information, like, have you seen it? Do you deal with this? Do you know what this is? And it came back with a textbook. Well, if this is what you have, you need a fusion or a resection. And then it was just crickets. So have you, I, I really, really, really want someone in Canada, like a medical, like a university or somebody to take this up. So have you had any of those conversations, or do you have any contacts in Canada, or is it no? Are we still in
No,
early
but
days?
you know what? I would love to make some contacts in Canada. And if you could share this flyer or my contact information with them, I would love to reach out, host a data collection event day at their university, or give a talk on the syndrome from a rehabilitation perspective.
Okay.
Because the more we can educate, the better off we all are.
It's still very early days, but I'm doing what I can, but thank you.
Thank you.
Thank you, Andrea. I have a lot of questions. I just want to see if others have other questions before I bombard you.
I just have one short question.
Go ahead.
Yeah, I recently had a resection. I'm type 2B as well, and my issue was primarily on the left side. So working with Dr. Haynes, we decided to just take out or basically just resect just the left side. So there is that enlarged transverse process on the right side still. Granted, that complicates the data. So I imagine that makes me ineligible to participate in this study because then that compounds the data because unless I say I'm type 2A at that point,
Yeah, I feel like
yeah.
that's an interesting question because you've had a partial surgery, not the complete surgery. Um,
Yeah.
Let me reach out to the chiropractor on my team who's reviewing all of the medical imaging and just bring up that
Hmm.
question because if you're saying that, I'm guessing there's a few of us else who've had partial surgeries because that would conflict the data, but you still have part of your BSY anatomy. So let me find out and I'll let you know what the consensus is because that's the first time I've been asked that question. And the more of us I can
Yeah.
get, I would love to.
Awesome. Yeah, no, I'm curious to get that to get that input. I did so like out of personal curiosity, I was able to was working with like a personal trainer here to do gait analysis, but I don't think it's the same exact one. We were using like the valve like system, so I have like comprehensive report, but I don't think it can be harmonized with your specific data. But I'm more than happy to provide that because I did that before surgery as well
Okay.
as after surgery, and then like like I'm planning to do it like now it's 5 months out since surgery, but I'm trying to like at end of one, but I was trying to kind of find some trend line on like potential changes in gait. But would that be interesting to you? Because like we can talk about this offline, but would that be something interesting? Because I would like to discuss that with you as well and kind of just dig through the data.
Yeah, that would be really interesting because I would love to do a more long-term study like that if my graduation timeline wasn't spring of 2025. Part of the study was like, okay, I can't measure everything, and doing a longitudinal pre and post surgery would probably be a good 5-year experiment. So hopefully, as
Yeah.
I continue this line of research as a professor instead of as a graduate candidate, because I would love to see what that looks like and be really curious to see your data. So thank you for sharing.
No worries. I'll reach out via email or something. But yeah, thanks. Those are my two questions. The last thing is, can I share just like if I were to disseminate that information for the like to participate in the study, is it just the flyer? Is there any other additional information you'd like me to include as part of like an email, as I send out some like a newsletter?
Oh, that's a great question. Just the flyer is fine. And if you want to add on anything about how it's completely okay to just do the first part, I've got
Okay.
a lot of questions this week about, oh, I didn't want to do it because I can't do all of it. Like, no, I made it online because I know not everyone's gonna travel.
Okay. Like just tell them that it's just you can do just the online one version and that's more than fine.
Yeah, because that
Okay.
still answers half of my research aims and gives us more data than I'm going to get in person.
Awesome. Alrighty. Well, thanks a lot. This is quite an interesting research.
Thank you.
Um, Thank you for all the questions, and thank you, Andrea, for setting up this study. It looks very cool and very a lot of information. Um, is it correct then that anyone who has had fusion or resection on both sides are excluded?
Correct.
Okay.
So I don't have enough of a surgical or orthopedic background to be able to compare um, post-surgery. The goal is to really see what it looks like pre-surgery because theoretically after surgery we have typical spines, or then it goes into um, people who've had spinal surgery, and it's known that that gives you a different gait pattern, but it's not known how Bertolotti syndrome patients who've had spine surgery compare gait-wise to just typical low back surgery.
Yeah, I would have loved to do this study because, like, would have loved to see how, I love how you have it divided in like knees and ankle and, hip and where it shows up red because we don't have a normal anatomy, right? Even after fusion or even after resection, we all deal with so many collateral damage, that it is still there. So in my mind, it's like I would have loved to also see, a report and doing this study for like post-surgery people. And also, do you think, I guess even, whenever someone does this study and they have the report, do you think it will also help them to go to their PT and say, hey, this one, like in your case, it was, I believe, the ankle that was like both red. Do you have to work on those? Because I don't work on my ankles at the PT, for example. But after the surgery, at some point, I did have a lot of pain on my left knee and ankle also. So would that be also something for, the people in your cohort to be like, hey, this is valuable for me to do this because then I have this report and I can even do these PT exercises and go to my PT, PT who listens to them, and then readdress their exercises, for example.
Yes, I think this could be one, just it's great information. It gives you a full body scan, which is something we try to do in the rehab world if we have the time and the flexibility to actually watch how our patients walk. Doing any kind of eyeball analysis is something that we're really good at as clinicians, but having that motion capture software that is able to give you the exact measurements that you're kind of thinking about, but you can't capture it that accurately without a camera system, adds so much data and richness to the evaluation. But also long term, I could see this being the standard of care for Bertolotti's patients. If you are considering spine surgery, do a gait analysis, get that pre-data, have the surgery, do the rehab, come back, get the post data, and really see what the functional outcomes of our surgery is, because I think that's one area that's missing in orthopedic care is we come in with so much deficit, so much pain, so much lack of function, and then we get the treatment and it either works and we never follow up, we go on and we live our lives, or it doesn't work and we continue to have these issues. But not having that comprehensive pre and post data puts surgeons and clinicians and patients in kind of a black hole of information. So I think this motion capture system could be a really great way to enhance that. And from the evaluation standpoint, I'm having you stand and walk in a treadmill for 5 minutes. So that adds 5 minutes to your appointment. It takes probably another 5 minutes on either side for me to turn on the camera and put the stickers on and take them back off you. But if we get that much data from an extra 10 minutes of an evaluation, I think this could be a really crucial step to better understanding Bertolotti syndrome pre and post surgery.
Yeah, that's great. As mentioned, many of us have like collateral damage or also other conditions that go with Bertolotti syndrome, for example, EDS. How do you take those into account? Because that can bias your outcome of like how much is Bertolotti syndrome contributing to the outcome as opposed to someone who has like EDS or like cranial other issues, or even like age or how long they have been dealing with Bertolotti syndrome, like someone who has had it for 1 year versus someone who has had it for 10 years. How can you take those factors into account?
That's a great question. One interesting thing about this line of research is I'm one of the early clinicians doing actual patient testing. So there aren't any kind of normative data sets to pull from. So what I will be doing to kind of make sure I'm on the right track is a lot of correlative statistics between each individual aim that take into account age, that take into account gender, that take into account the other syndromes and comorbidities. Part of the screening process for the study allows me to ask, like, what else do you have going on? So the more richness I get from that, the better I'll be able to put the data in context. Because Bertolotti's patients tend to have so many comorbidities, I've left it really open. So I'm excluding you if you've had corrective spinal surgery, because then you don't have your Bertolotti's anatomy. And I'm excluding you if you have a current acute injury, such as like hip surgery, or you fell and you hurt your knee. Like if you have something else that's going on that I know is directly impacting how you're walking, I can't count that as the data set. But for everything else, I can compare, because we know gait changes as you age. and there's a normal trajectory. So what I will be doing is matching that up using a normative data set to see if we're in range, if we're out of range, and kind of what that looks like. And then the other piece of that is I don't know what 20 people I'm going to get to collect data on. So will it be people of the same age? Will I get a wide age range in between there? And that'll determine the results too. So part of the study will also be setting the groundwork for future studies to come. So suggesting this as a pre-post protocol, suggesting to expand the ages. I would love to go in a younger age range. Unfortunately, it's really hard to conduct research on anyone under 18. There's a lot of extra red tape around that. So that's why it's set at 18 and above, but there's no age window. I could be collecting gait data 90-year-olds to 70-year-olds to 30-year-olds. So it's going to depend a lot on who I get as a sample. And then all of that will be disclosed in the results as well.
Yeah.
Just to quickly follow up, sorry, Kit, you
Yeah.
mentioned you'd love to work on people below the age of 18, so at an early age. Is there like a particular reason for that? Is it like anatomical, or is it just that growth plates are still developing? Like there's some issue there. Like what's the kind of scientific rationale for that?
Twofold. I've gotten a few messages from people that are like, hey, my child is 17 and a half. Can they do your study? And I'm like, no, I'm sorry. Like IRB said 18 and up. And then the other piece of that is typically Bertolotti's become symptomatic in our mid-20s, but this is anatomy we are born with. So if we were able to know, like if we had an infant and we studied them all the way at every milestone, that would just be fascinating as a kinesiologist to see how does this anatomy differ? When are we able to really pinpoint what's going on? Because what if we could capture our unique movement patterns before the pain and before the disability and the fatigue start to set in? That could really change the game on how this is treated.
That makes a lot of sense. When it comes to like your research, like are you there's a lot of asymmetry that you see like even in yourself, and I noticed that in mine. Do you also take into account or try to capture potential changes like or asymmetry in muscle development? At least that's something like even in my analysis I try to look at, and it's just musculature like on the left side, the like glute med is kind of underdeveloped or hypotonic, and then the quads and the calves are like more developed than the right side. Like there's some sort of compensation that has happened for so long that it leads to like this adaptation. Is that something that I guess currently being captured in your study, or is that something that you may be considering in the future?
Definitely considering in the future, I would love to do a more in-depth study if I could find maybe 5 or 10 patients I could commit to coming in for multiple clinic sessions to get some of the muscle testing done. Indirectly, balance and posture and gait can start to paint a clinical picture of what might be causing the muscle imbalances. And the other tricky part with measuring the muscle imbalances is just knowing like when did this start? Because we think that humans are really symmetrical, and best case scenario we should be, but we're not. It's really common for us to have, a half-inch leg length discrepancy. It's also really common for us to be stronger in our non-dominant hand than our dominant hand, oddly enough, because we use our dominant hand for little fine motor details and our other hand for brute strength. So if you think about like which hand you turn the key with when you try to get in versus which hand you shove the door open with.
Yeah, it's like crabs, I guess, the what's it called? The crusher and the pincer.
Exactly. So trying to figure out like, well, why do you have this? And I would need a huge pool of Bertolotti's patients to really be able to come up with whys instead of just going, well, there's some abnormalities here. And us as patients going, we know this already. We live with it.
Okay. No, that makes total sense. Sorry, last question is for this research, do you have like a normal patient pool to serve as a baseline to kind of, you know, what's it called? Yeah, like it's similar to I imagine like the patient like age pool may not be the same, but just having like that normal gauge, normal all the analysis just to serve as a baseline, or is it just using kind of published data that serves as the kind of universal baseline?
Yes, so the second one. So for the sake of time management and cutting my recruitment in half, so this way I only need 20 people and I don't need to age match comparison because that can be really tricky to find an age match comparison that doesn't have their own confounding health issues. So each
Hmm.
one of the aims is measured through a specific instrument, which is age-based normed. So the SF-36 has a normative score range that's been tested and is tried and true. Same with the postural analysis. That's already a norm measured tool. And the Y balance assessment is measured against same age peers, and same with the run DNA. So it's giving you your asymmetries based on the hundreds of people that they've already collected data on. So then all I have to do is measure your data against these measures, and that kind of gives me that window of typical,
Hmm.
atypical, how far off are you from your peers? If you're far off at all, we don't know.
Hmm. No, that makes a lot of sense. Yeah. No, thanks.
Yeah, that's a great question, though.
Will be also interesting to see. I know this will, will not be in your current cohort, but like those that do have a LSTV but does not have pain, like do they have pain elsewhere or do they show red, in the report like red um, signal popping up, but in other areas, that will be also interesting. But that's for your third study, maybe.
Yeah, exactly. And it's like anything I don't capture here, like we're going to
Yeah.
continue this line of research and just keep going until we
I
really solve
know.
this
There's so much
syndrome.
work to do. Yeah. Um, I have some last questions. So you mentioned about your type, and according to the report that you showed on the left side, there were more red signals popping up. How's your pain experience? Is it more on the left side? Like, do you literally feel more pain, I guess, left side of your hip, left side of your knee? And both foot ankle.
Um, that's a great question. I think I don't notice a consistent difference on pain on each side. I think part of that also stems on what I'm doing. Like, did I sleep on my left side? It's going to hurt a little bit more versus if I slept on my right side. If I'm doing any kind of long distance drives, I'll notice like, oh, my right hip gets a little bit more sore because the right foot's pushing on the gas pedal. But when I look at the image of myself walking, I'm really able to see how I'm planting one leg and having to hike and swing the other one over. So as I'm watching this, I'm able to just see like, oh, like one side is working a lot harder than the other one. And instead of keeping my pelvis in a neutral line, it's tipping back and forth to get each single step. And I notice after a lot of walking or standing around, like my hips do get sore. In addition to the low back and the stabbing knife Bertolotti's pain, like I'm also noticing my hips are tired. But part of Bertolotti syndrome is noticing that like we also probably have a few other things going on, and I do have some other hip issues that could be impacting this data. I have labral tears on both hips, and I have coxavalga where my hips are in a little bit deeper than they should be. So that's also creating some additional strain that might be showing up in the gait report here.
I see. Um, in addition to these, is it possible, because like trunk is large, right? Is it possible to, I guess, include a cervical part to it? Because many are having issues with the cervical area. So I don't know how when you have the motion detecting things, can you still put an additional sticker to that side of the body?
Actually, way up here at the very tippity top where that last white dot is, that is on your C7 spinous process. So I'm
Oh.
able to measure all the way up from C7 down to your trunk to look at the trunk rotation in gait.
Hmm.
It's Harsh, it's mostly capturing your trunk because there isn't a large data set on what your neck is doing when you're walking.
I
So,
see.
not being a biomechanist myself, I don't have the mathematical foundations to understand that analysis
Mm.
without spending a few more years in the lab conducting that. But I know that the neck issues are an issue for so many of us, myself included. And part of that is just due to the force loading because our lumbosacral vertebrae should be carrying at least 50% of our spinal load. And when it is misshapen, like many of ours are, it's displacing the force. And because our points of curvature at our spine are so much weaker, they're often the first places we experience osteoarthritis breakdown or degenerative disc disease. And our neck gets the worst of it because our neck has to carry our head, which is just this huge weight that is constantly pushing down on us. So it tends to be the first point of weakness for so many of us, just based on spinal loading patterns.
Mhm. Okay, thank you. I promise the last question for me is your study has 4 parts, correct? And
Yes.
then the first 2 are online.
Yes.
Yes, but the first one, I believe it was a survey about how you experience Bertolotti and stuff. Can those be filled out by people who have had surgery, but then they kind of like retroactively think of when they were experiencing Bertolotti pain? And would that help for your study? Or not at all because
No, because it would need to be the same pre-surgery people because what we found with people doing those clinical questionnaires, they're long. We tend to kind of peruse through them, and it shouldn't take us any more than 5 or 10 minutes to complete them because if we're spending too long, then we're overthinking it and we're maybe not giving the most accurate data. We're trying to think back about what does this questionnaire want or what do I want to tell the researchers? So unfortunately, it would need to still be people pre-surgery, so they're giving their accurate day-to-day current experience. But that's a great question.
Thank you. I see the chat, and Donna has a question. She said, I've already had surgery. I would have loved to be part of your study. I would have loved to have a gait study done. How and where can we find one in our area?
Ooh, that's a great question. A lot of running and walking stores will give you a really short gait analysis as they try to sell you their shoes, and they are trained in this. It's most likely not to the same high level computer standards.
Yeah.
The company I'm using is called Run DNA. They were kind enough to sponsor my research study, train me in their software, and loan me their equipment to collect this data. And they have set up their system so that it's available for clinicians all over the world. So if you Google where can I get a Run DNA walking analysis, that might give you a few places that are close to you to see who has it around you. Because I think a lot of clinicians use this system. I know a lot of researchers do, and the issue is just like, are there any close to you? Because that can kind of be concentrated to bigger cities or university lab research. It's not always widely available, unfortunately.
Yeah, I'm Googling it, and there are. It's very interesting.
Oh, good.
Yeah. I
Yeah.
shared a link on the
Yeah.
chat. So like that gives you like that's Run DNA's place. You can put in your zip code or whatever, and it will show you all the nearest facilities in your area that you can go to.
That's very cool. Yeah, I see two in Boston, so I bet like I see a lot of dots, so they're in a lot of areas.
And then I would just give them a call because they initially started as a running analysis software. They do walking analysis, but just making sure like their specific site is set up for walking and running analysis. Because I'm guessing most of us here don't want to go for a run. I know I don't.
I see here it's with a PT, and then it's like 60 minutes for the running gait analysis and injury risk assessment, $235. Of course, it's not free. So that's why people should participate in your study so that they get it. So, get the value out of it and help the community. That's funny. But yeah. Okay, I have no other questions left. In the chat, I see no specific questions. Anyone who has any other comments? Otherwise, I will stop the recording, but we can still stay and hang out.
Okay, thank you guys.
Okay, thank you, Andrea.